This approach to dysphagia, that is difficulty swallowing, which is different than odynophagia, which is painful swallowing, is less about keeping track of the diseases and more about keeping track of who you call. So the first thing you need to do is decide, where does the food get stuck? Almost exclusively, dysphagia is difficulty swallowing food, but more like it feels like it gets stuck somewhere. So this is a guy's chin, looking up, neck, clavicle. The first thing you need to do is say, where does it feel like it gets stuck? Because if it is above the clavicle, it is oropharyngeal. And if you want to take a look, you can't call GI. If you want to take a look, you need to call ENT, and they can use a laryngoscope. People think, trouble swallowing, that is the lumen of the GI tract, I should call the GI specialists. The problem is that to do an EGD, the patient swallows the camera, and they essentially start looking right at the clavicle. So if you have oropharyngeal dysphagia above the clavicle, they can't see it. So you don't want to call the wrong person. If the food gets stuck below the clavicle, that is esophageal. And therefore you can call GI to do an endoscope. Basest form initiating clinical reasoning. Where does the food get stuck? That of course is a little more complicated than that. So we've already said that dysphagia can be divided into two types. Oropharyngeal and esophageal. In addition to where the food gets stuck, to make sure you don't call the wrong person, oropharyngeal dysphagia will be described as problems on initiation. It takes a coordination of a lot of muscles to swallow a food bolus. And whether it's coughing, choking, gagging, whatever, if it's on initiation, it's almost certainly oropharyngeal. And now you know not to call GI, but who do you call? The thing is, for oropharyngeal causes, it's almost always going to be an interruption of the signal to swallow to the muscles that actually do it. So lesions are generally going to be neural in nature. Lesions of the vagus nerve, multiple sclerosis, transverse myelitis, and the most common cause, stroke. Now, can you have a tumor that causes oropharyngeal dysphagia? Yes, and that's when you call ENT to get the laryngoscope. But in reality, it becomes more of a neural disease. And usually it's, you know that disease is there. It's not the dysphagia is the presenting complaint. Sometimes it could be, right? But most of the time they have a stroke, and so you assess them for oropharyngeal dysphagia, which is why every patient with a stroke sees speech therapy. Speech therapy does assess and train speech, but they also assess swallowing and cognition. And if they do their bedside assessment and think, this is bad enough to need further evaluation, they can do a pharyngogram, where the patient swallows different consistencies of foods. They've been radio-labeled, and they assessed for how bad is the oropharyngeal dysphagia. Do they silently aspirate? What consistencies of food do they aspirate on, and which do they not? And they can make recommendations on what type of food the person can eat, and then training. And sometimes it simply goes NPO, where they need an NG tube or a feeding tube. Oropharyngeal dysphagia, initiation, almost always going to be neural, speech therapy. Esophageal dysphagia can be further broken down into motility and mechanical. Motility is functional. There's nothing wrong with the structure of the lumen. The muscles just don't work. And this is muscles of the esophagus. And there's also mechanical. Mechanical is obstruction. Something is growing into the lumen. rather than write off a bunch of diagnoses, which you could attach to these, I like to think of it better as what do you do next? Because you know you're calling GI. A motility disorder is going to be one that presents with food and liquid dysphagia. It doesn't matter the consistency, the size of the food bolus, or how frequent. Motility disorders generally have food and liquid at the same time. On the other hand, mechanical diseases tend to be worsening and progressive. So they'll have food dysphagia, then liquid. It is the progression that tells you it's mechanical. And here's why I don't really think it's necessary to put in a bunch of diagnoses. The next step for both is to do a barium swallow. Because this next step after that is an EGD. Now technically, if you're taking an exam, the next step for motility would be manometry. In life, if the person's been admitted for dysphagia so bad and you're calling GI, you don't really have time for the manometry, right? You get the barium to give the GI guys a gist of what's going to happen, and the manometry just happens later because you get the scope and the biopsy. If it's mechanical, you get the barium to, hey, give them a heads up to see what it's going to look like, and they're going to do an endoscopy. If you have an outpatient with the not severe dysphagia, and along the process you work them up, and you get manometry on their way to their GI appointment so they can set up a follow-up EGD, manometry is the right answer. But practically in the hospital, if someone's admitted for dysphagia, they're going to get a scope if it's esophageal, and if it's oropharyngeal, they're going to get speech therapy. And you still might call in GI if this patient's determined to need a PEG tube. And that is the approach to dysphagia.